Thank you. Thank you very much. I have no idea what I'm doing in this symposium. This is supposed to be oculofacial aesthetic symposium. But I suppose the only thing the link I can draw is when Dr. Grover finished his talk, and Dr. Shalu finished her talk, they talked about visual loss. And that's a disaster in any ophthalmic surgery. So I think this is the only link that we have. Anyway, I'm going to share with you on behalf of the oculoplastic community and the trauma community about some of the challenges. And more often than not, most of us surgeons are all guilty of showing us, you all, the best cases we always have. It's not often that we share the disasters, and I think this kind of talk is going to drive home those points about disasters, why you should be very sensitive to certain aspects of various aspects of ophthalmic surgery, oculoplastic surgery, and orbital surgery. Every single time you do a ptosis surgery, every single time you do a blepharoplasty, the moment you open the septum, which we almost always do, it is orbital surgery. It's not just eyelid surgery. Anyway, I'll invite you to the conference on trauma in July in Chennai. Please do submit your abstracts and join over as well. Only conflict I have is this book, which is coming out very, very soon, which is going to be a comprehensive treatise on all things related to orbital fractures, the past, the present, and the future. So when you talk about pitfalls in any aspect of medicine, we're talking about diagnostic pitfalls, we're talking about therapeutic pitfalls, and worse importantly, once you've touched the patients, the various surgical complications. For the interest of time, I'm going to classify the disasters into major, real, serious, which is both medical and medico-legally significant, and not so serious, but just as bad complications that you are actually embarrassed to face and manage as well. The worst of any complication is death, of course, and can you die during a process of fracture repair, or even a blepharoplasty, or even a cataract surgery? The answer is a big yes, so don't ignore that as a possibility. Hence, the medical workup of the patient is very important. But I'm going to emphasize a little bit about blindness and double vision. These are the two major potentially avoidable complications, and we'll talk a little bit about it. And I'll touch on a little bit about residual deformities, xenophthalmos, and the late complications itself. So what are the major causes of visual loss? Undiagnosed globe-related problems or globe complications that you cause during itself, and various forms of optic neuropathy. If you look at this child who's had a medial orbital fracture repair, what you don't see, and relatively less visible, is this implant that has been placed in the name of repair of a medial wall fracture repair, and there's a subperiosteal hematoma, which is extended on to an orbital hematoma because the periosteum is breached. Grade 2 to 3 RAPD. That's a classic example of a visual loss, which is iatrogenic. Why? Because the anterior and the posterior ethmoidal arteries were violated and breached during the surgery, which was ignored. So hence, knowing the vascular anatomy of the orbit is very important. These are the important arteries which are usually not given major consideration during your viva exams and postgraduate examinations. And having a healthy respect not only for the arteries, but the venous circulation is also very important. So you should be able to avoid, and when present, manage a compartment syndrome. We don't call it a retrobulbar hemorrhage anymore. And a major misconception as a cause of visual loss is CRAO. It is not the retinal artery that gets occluded. Even subtle but significant raises of intraorbital pressure can actually occlude even the smaller PL plexuses which supply the optic nerve. Those are what cause visual loss, not central retinal artery occlusion. Okay? The second major disaster following any patient who never had preoperative diplopia when you're doing fracture repair is inducing a new onset diplopia, not from transient myopathy, but from various acts commitment that we do as well. Dissection for these patients should be as atraumatic as possible, so you don't want to induce a myopathy which was never there before. You want to make sure you want to reduce all the contents, and by the time you stick your implant in, all orbital contents should be free, and actually very difficult to do, of course, real optic of a neuropathy as well. This is a patient 3 days post orbital fracture repair. The oculoplastic fellow says, I've done a good reduction, see, and shows off the CT scan. What that person is actually avoiding and showing you is that posterior placement of the implant, which is not against the posterior ledge, because there's no posterior ledge in this patient, but much higher up, and that causes an induced diplopia, and the only way around it is to be prepared to go back and try to take out this implant. Okay? Induced complications from either failure of technique, lack of visualizations of the orbit, or an implant which you're not comfortable placing is one of the major causes that you should be aware of. Here's another patient who also was referred by another oculoplastic surgeon from overseas and said, I've done a good orbital fracture repair. He's got a left hypertrophy and diplopia. Look at his fracture repair. There's a silicone block in the anterior part, no reduction, no correction of the posterior part of the floor of the orbit. Okay, there's still muscle incarcerated and herniated. This is not an adequate fracture repair. Okay, so these are the patients where you have to manage them initially conservatively and then subsequently go ahead, do a revision fracture repair followed by residual strabismus surgery if necessary. How about underdiagnosis? Pediatric fractures which are missed because either the X-rays are done or even a CT scan is done but an orbital fracture is missed, or delayed surgeries performed pediatric fractures is one of the highest indications for secondary strabismus repair. Because if you miss the golden period of 24, 48, 72 hours, the younger the child, the earlier you go in, no matter how beautiful a correction you do, you're going to have residual diplopia. So beware these patients with bi-type blowout fractures where you don't want to miss a diagnosis just because the CT scan site findings are not very obvious. How about relatively minor complications but still major problems as well? Examples of patients who had quote-unquote facial injuries repair, fracture repairs done, and you don't even know what's happening to the right side. Look at the reconstruction that has been done. Implants are placed not inside the orbit, but into nasal cavities and ethmoidal sinus cavities as well. This is where lack of anatomy, orbital fracture repair is more than just opening the orbit and doing some surgery and sticking an implant inside, but knowing exactly where you place the implant is very, very important, and no surprise, a lot of our patients have residual deformities. Here's another patient who was in the intensive care unit, had profound visual loss, early post-trauma, and had a previous repair done. And look at the way his fracture has been done. If you look at the orbit on the right side, the zygoma has not been reduced, the floor plate is somewhere in the maxillary sinus, not in the orbit itself. So a lot of these fractures where we have to do revision surgeries here now to undo the damage done by the first surgeon and then go back and reconstructing it. This is the same patient where we had to go to do osteotomize, reconstruct the floor, reconstruct the lateral wall and the medial wall before we go ahead do additional repairs for the globe itself. Here's an example of a patient who's got a floor, combined floor and medial wall fractures, where with good techniques, preoperative assessment, pre-bending or anatomical prefabricated plates, you can get almost mirror imaging of a precise reconstruction of the angle of the inferior orbital strut, of the medial wall, of the floor, and any good structural outcome usually is followed by good functional outcome and a happy patient. How about enophthalmos? The main reason for enophthalmos is lack of restoration of premorbid orbital volume itself, whether it's a floor, medial wall, whatever it may be. And we are sometimes not aware, especially when you read our standard anatomy textbooks, they draw the floor as one straight line, but actually there's a posterior convex plunge. Yeah. That's where, again, anatomical correction of these implants is very important. No surprise, when you have a large fracture, you just put a flat sheet, whether it's silicone or porous polypropylene, whatever it is, you still get enophthalmos, even though you've done a good adequate dissection itself. But all enophthalmos can be secondly corrected, but albeit with the residual morbidity itself. Examples of patients, this is a patient who's had surgery 3 different occasions for the orbit with the deformity there is, who had to be reconstructed with multiple revision surgeries. The last complication I'm going to talk about is the implants that we put in. We have palpable implants, exposed implants, infected implants, and these are all consequences from permanent implants that we use. And we have a choice of implants, and every time you have a choice of implants, you have the opportunity to tailor the implant to the fracture, rather than this only implant I'm familiar with, I'm going to put this implant inside all these fractures, and no surprise you have complications. So if I show you the CT scan of this patient, where is a fracture? This is all just sinus mucosal polyps. There's no fracture at all. And what if I told you the same patient CT scan 18 months prior to this? So this is an example of combined floor and medial wall fracture where we put a bioresorbable implant. The bioresorbable implant has formed a scaffold, fibrous scaffold, around which new bone is formed, and the bone is completely healed according to the way you have reconstructed the orbit as well. So there are certain group of patients, and in our practice, about 30 to 40% of our patients who you have bioresorbables done, thereby you don't have to meet with the late postoperative implant-related complications. So in summary, in the short 10 minutes that I've had, although there's a lot more to talk about, orbital reconstruction is like everything else in oculoplastics, is quite challenging, yet satisfying when you do a good job as well. You have to have a comprehensive, methodical, pre-operative evaluation. Surgical technique has to be precise, and I think Devraj and I were talking about doing fellowships and doing your surgeries. Your first disasters come and after you really start doing your first games. And like a lot of things in life, the first time is the best time. So our patients should be getting better not because, okay? Read this again, because of what we do for them, not despite what we do to them. Thank you very much again, and sorry to interrupt the aesthetic session.